So good day, everyone. I'm Daniel Auclair, the Chief Scientific Officer at the Multiple Myeloma Research Foundation, and I'll talk to you a little bit about what we're doing around precision medicine. You know, up until now, most of the agents used in multiple myeloma are targeting the plasma cell biology of the disease. The fact that they are plasma cells, so they make a lot of immunoglobulins, so they need to have a fine-tuned protein machinery. And any agents that would disrupt that fine-tuned protein machinery, like proteasome inhibitors and to some extent IMiDs, will be very toxic to these myeloma cells, which we are seeing. And on top of that, because they are plasma cells, they do express surface molecules like CD38, like SLAMF7, like BCMA, which make them, prime therapeutic targets. But what we've seen is, despite all these great agents that we have and all the progress that has happened, there's still upfront 25% of myeloma patients who derive little benefit from these agents. And as they relapse, as patients relapse, they go more toward that, very higher risk type of disease, very more proliferative disease. And through efforts that we've done, like our MMRF Compass study, what we've discovered, what others have discovered, is over 75% of all these high-risk patients have these so-called actionable alterations. Alterations, for example, in the MAP kinase pathway, in the cyclin-dependent kinase pathway, alteration around genes like IDH1, IDH2, for example, for T1114 patients, they are exquisitely sensitive to BCL2 inhibitors like venetoclax. So we thought about, let's try to go after this oncobiology of the disease, try to make some inroads, really going after what's driving the very aggressive type of cancer these patients have. And so that's how we derived this MyDrug master protocol. And I think in this case, as well as in other cases before, venetoclax, which will be likely the very first targeted agent approved in myeloma, there was a large randomized phase 3 trial called the Bellini trial. And what we discovered is really the trial had to be stopped because there was a safety signal. But when researchers went in and dig into this, they figured out that actually the patient who had the biomarker were the T1114, had some great benefit from a PFS and COS perspective, and didn't suffer the same toxicities as those who didn't have. So the principle is, if you have a biomarker, if you believe you have a biomarker, use it. So in our MyDrug Master Protocol, which I presented recently at the ESH meeting, we have arms for MAP kinase pathway alterations using a drug called cobimetinib, which is approved in colon cancers and other. We have an arm for alteration in FGFR3 alterations, which drug just got approved recently in bladder cancer, for example. We obviously have venetoclax, which is approved in other blood cancer, as well as enasidenib, the IDH1, IDH2 inhibitor. As I presented, we're already starting to see some real interesting results using targeted agents, which does show that there is the possibility to do precision medicine for these high-risk myeloma patients who are not benefiting. And there's, that's really the future. And beyond targeted agents that are going after the genomic alteration, the next step is targeted immuno-oncology. Myeloma patients, there's also a group of them who are hypermutated, have a large amount of mutations. And such patients do benefit from PD-1, PD-L1 agents. As we've seen, these studies had to be stopped because, again, there was the principle I told you, if you have a biomarker, use it, was not used here. And as we've seen in solid tumors, PD-1, PD-L1 agents do not benefit very much if they're not deployed in hypermutated tumors. So in finishing, the hope for precision medicine is that, cancer already has two coin to it. the blueprint of the tumor of the cancer itself, and then how the immune system is modified and react to to basically the disease and to treatment. And precision medicine in myeloma will be about bringing these two sides of the coin together, using targeted agents that can specifically go after alterations in given individuals, and then unleashing the rest of the immune system to amplify this response. And with this, I thank you.